And just to provide a basis for our discussions today, I will confine my comments and the discussion to single tooth replacements in the anterior maxilla, where aesthetics, of course, is of importance for our patients and, of course, for outcomes, both short-term and long-term. And as you can see in the images in front of you, the healing patterns that occur in the early stages of tooth extraction are quite typical and something that as clinicians we are very used to seeing. So when a tooth is taken out, you immediately begin with a blood clot that forms within the extraction socket, and then a granulation tissue forms within it. And within 4 weeks, which you can see in the middle image, you start to see some immature soft tissue forming over the surface to close over the extraction socket. And at the same time, some flattening of the ridge from the facial aspect, as well as a slight thickening of the soft tissues on the facial aspect. And by 8 weeks, the soft tissue healing is almost complete, and this further flattening of the ridge has taken place, and you can see that as an alteration in the contour of the ridge from the facial aspect, which is typical, as I said, of the early time frame after tooth extraction. So these are the soft tissue external changes that we see, but what is happening underneath? Well, to demonstrate this, what I've done is looked at several studies, clinical studies with re-entries, measuring the changes in the facial bone dimensions from 8 weeks up to 12 months. And this is put together in a composite image or graph, as you can see on the screen in front of you. So if we look at the horizontal or the orofacial change in the ridge from the facial aspect, this is depicted in the blue line. And you can see it is a gradual change over a period of 12 months. It takes on a fairly linear curve over that period of 12 months. In contrast, the vertical change or the coronoapical change of the facial bone occurs very quickly in the first 2 months. We already see about 1.5 millimeters of vertical change, and then it tends to flatten off over a period of time. So we can see the pattern of resorption and subsequent modeling of the facial aspect of the ridge in the horizontal and vertical dimension is slightly different. Now, of course, this relates to what happens to the facial bone wall. In the first 3 months, the overriding healing pattern is one of resorption of that facial bone of the socket. Subsequently, after 3 months, we start to get modeling changes of the ridge. So these are two different mechanisms that are occurring. But of course, what we're interested in the early stages, when we talk about immediate or early implant placement, is what happens in those first 3 months, or in that period of time where active resorption of the buccal bone or the facial bone plate is taking place. Now, this may be explained by the so-called bundle bone hypothesis that was put forward by Maurizio Araujo back in 2005. And the explanation for this is that when a tooth is supported within the bone through the periodontal ligament connects with the bone surrounding the socket into specialized cortical bone, which has been referred to as bundle bone. And when the tooth is extracted, the bundle bone, which supports the tooth, no longer has a reason to be present. And this bundle bone occupies a space of about 0.5 millimeters around the in that cortical bone that confines itself to the socket itself. So when the tooth is taken out, and if the bundle bone no longer has a reason to exist because it no longer supports the tooth, then the body naturally resorbs this bundle bone away. And on the facial aspect of the ridge, where the bone itself is relatively thin, then the bundle bone often occupies the entire thickness of the facial bone plate, especially in that coronal portion. And ultimately what happens then is a resorption of the ridge that takes place through both a vertical loss of the facial bone height, as well as a horizontal loss of the ridge once the modeling processes start to take place. And of course, this then leads on to dimensional changes of the ridge that we see typically once a tooth has been extracted. And of course, this has significant aesthetic implications. What I'd like to do is share with you a study that was published last year by our group, and it's a preclinical study in a canine model. And here the objective of the study was to compare two types of implant designs, a bone level implant with a bone level tapered implant, so a parallel walled implant with an apically tapered implant, into immediate extraction sites. And here we use the maxillary second incisor sockets in the dog model, which is more closely, I think, relatable to what we see in a clinical situation when we place implants in the anterior maxilla. Now, ISQ was used to measure the stability of the implants at the time of placement, and that was the primary outcome measure. But we also looked at histology, which is really what I want to show you for this study today. So here is the study design. 9 pairs of maxillary second incisors were used, so contralateral, and randomly selected for either a bone level tapered or a standard bone level implant. The teeth were carefully extracted with a flapless extraction technique, ensuring that the facial bone was not damaged at the time. And then the implants were placed according to the manufacturer's instruction, taking care that the facial aspect of the implant shoulder was at that facial bone crest. So typically of what you would do clinically when you place an implant immediately into an extraction site in a maxillary anterior region, and you're attempting either immediate loading or a delayed loading protocol, but the positioning of the implant would be similar. And at the same time ensuring that a 2 millimeter gap was maintained between the implant and the internal aspect of that facial bone. And into that defect, deproteinized bovine bone mineral was grafted, and this was in a collagen sponge, and then the graft was protected and sealed off with the manufacturer's 3D collagen sponge. And this was then allowed to heal for 12 months, for 12 weeks. Now, at the time of implant placement, ISQ was done, and it was shown that the mean ISQ for bone level tapered implants was significantly greater than the ISQ for bone level implants. And so it was 66 versus 60, so a 10% difference, which was highly statistically significant, leading to the conclusion that implants with an apical taper into an immediate extraction site achieve higher initial stability than parallel walled implants. Okay, so that was the primary aim of the study. But as I said, the histology was what was very interesting and pertinent to what we're talking about with post-extraction healing. So after 12 weeks of healing, what you can see on the histological image on your right-hand side is the tapered implant, and the green illustrates the biomaterials or the deproteinized bovine bone material. And you can see that this is now the regenerated facial bone consists almost entirely of the biomaterial or the bone substitute. Now, what you also will see is that the facial bone crest, and remember the implant was placed initially with the implant shoulder at the level of that facial bone crest. You can see that there's a vertical resorption of approximately 1.5 millimeters. So the immediate implant placement and the grafting did not stop the vertical resorption of the facial bone according to the bundle bone hypothesis. In addition, the width of the residual bone crest, and remember the implant was placed 2 millimeters from the facial bone crest, and that was grafted, but that showed a resorption or horizontal resorption leading to the residual ridge of about 1.4 millimeters in orofacial dimension. So the original 2 millimeters had reduced to 1.4 millimeters, once again demonstrating that in the early phase of healing, there is a vertical and horizontal reduction in the dimension of the ridge, even when a bone graft has been placed. In contrast, this study, and most of you will be familiar with this, it's to do with the socket shield technique, and as a proof of principle, this study demonstrates what happens when you take a tooth out, but you leave in a portion of the root which remains connected to the facial bone. Once again, it's in a dog model, but instead of the maxilla, the model utilizes the mandibular premolars, which have been hemisected and decoronated, and the distal root was divided, leaving a portion of the facial root face in situ connected by the periodontal ligament to the facial bone. And then they placed an implant immediately lingual to the retained root fragment, and then did histology. Now, of course, this is a mandibular case, but I've flipped the image around so it looks more like a maxillary case just for comparison purposes. And you can see on the left histological image retention of that facial root fragment, which is demonstrated as the capital letter D with the red arrow. And on the right-hand side, a closer image showing that after a healing period of some weeks, there is absolutely no evidence of resorption of that facial bone, which you can see remaining close proximity to the root fragment that remains in situ, and of course the implant further to the right-hand side. So there's absence of osteoclastic activity and complete preservation of the facial bone. So these two preclinical studies, one with a tooth extraction completely and an implant placement, compared to a partial extraction technique where some part of the root is left behind and implant placement, confirms the bundle bone hypothesis that the bundle bone forms a developmental unit with a periodontal ligament and the root cementum. And that once the tooth is taken out and that developmental unit is disrupted, the bundle bone resorbs. And this rapid resorption of the bundle bone then leads to post-extraction dimensional change. So there is convincing histological evidence to support this hypothesis today.